Hello, everyone. My name is Yuan Du. I'm an associate professor in the Department of Radiology at Johns Hopkins University. Today, we're going to talk about quantitative SPECT and some of its applications. There's a quick note of the conflict of interest. The outline of today's talk, I will first give you an introduction to the SPECT. Then we'll talk about how we achieve quantitative accuracy in SPECT imaging. Then I'll give you a few examples of the quantitative SPECT applications. SPECT stands for single photon emission computed tomography. It's a 3D imaging that measures distribution of radiopharmaceuticals injected into the patients. It's functional imaging. It represents the physiological or biological functions of the distribution of the tracer, which is the target different biology functions, as compared to the MRI imagings, which shows the structure of the brain as shown here. 3D image of SPECT is very blurred, but shows uptake of tracer. For example, here shows the brain blood perfusion as demonstrated here. So that's why sometimes SPECT imaging also called molecular imaging. This is two examples of the most current SPECT CT system. One on the left is the GE Hawkeye system. This shows the X-ray, and there's a single slice CT detector, and there's the head SPECT gamma camera. On the right is the Siemens Symbia T16 SPECT CT system. It has a 16 slice CT, as shown by a big ring here, and also it shows two gamma camera head detect for SPECT imaging. So how we acquire SPECT imaging? We first inject radiopharmaceutical labeled tracer into the patient. Then after a certain time, the tracer will distribute in the patient, and we'll measure the gamma rays emitted from patient. Use a gamma camera. We will circulate a gamma camera around patient body to take a 2D snapshot as we define as a projection image. And we do this through multiple angles. Then we'll get a series of projection image. Then we will perform image reconstruction, which provide us with 3D activity distributions. Here are some examples of the pharmaceuticals that used in SPECT. We are studying perfusion imaging in the heart, brain, and lung. We also study tumor metabolite, also use antibody labeled agents to study tumors. We can study organ functions. Some examples include thyroid, or kidney functions, or gastric emptying. We also have the neurotransmitter that's labeled with iodine-123 or technetium, which can use to study brain functions. The commonly used radionuclide in SPECT imaging are technetium, which has 140 keV photons with 6-hour half-life, and the thallium, which is commonly used for cardiac imaging, and iodine-123 is commonly used for labeled brain imaging, and iodine-131 which it can use for thyroid imaging and also some other imagings. The other commonly used agent radiopharmaceuticals include indium-111 and the gadolinium. So the most important part of the SPECT system is the gamma camera. As shown here, the gamma camera's component first is the collimator, which serves as a mechanical lens that filters out unwanted gamma rays. The gamma rays then will reach the scintillating crystal, which will convert gamma photons into visible photons, which will be detected by the photon multiplier tubes behind the crystal. Then the signal will be converted to electron signal and goes through the amplification and the pulse analysis to generate energy and position information used for imaging. Some important characteristics of gamma cameras include uniformity, linearity, sensitivity, spatial resolution, and energy resolution. Those can affect image quality of SPECT images. This shows you some simple projection data from a phantom of a brain from multiple views. So in order to get to the 3D image, we need to reconstruct from the 2D images into 3D images. This is the inverse problem. There is an analytical method and the iterative method for reconstruction. The most successful analytical method are filtered back projection reconstruction. It has a thorough theoretical framework. It's fast and very easy to implement. However, the filtered back projection reconstruction is sensitive to noise and missing data. Most importantly, it doesn't model any physics, as we show here, which can significantly affect image quality. The iterative reconstruction, this shows the basic framework of the iterative reconstruction. Is starting from initial estimation, then we project images to different projection views based on a model, mathematical model of imaging system and the physics. Then we can compare the estimated projection with measured projection based on a certain statistical criterion, which will generate update matrix we can use to update the estimated image. when we're going through this iteratively, we can gradually improve image quality and produce images which much better qualities than the analytical reconstruction method. So traditionally in SPECT imaging, a physician will look at the images and will decide the location of disease, then will define the type of disease. For example, the image here shows a dead SPECT imaging of a brain. On the left is a normal brain. We can see the stratum structure has higher uptake. On the left, the stratum with reduced uptake. Physician look at them. They can decide this patient has Parkinson's disease. However, this is very qualitative. It's not quantitative. Recently, the quantitative SPECT imaging has done a lot of focus. In quantitative SPECT imaging, we measure activity uptake in a certain region in the images. Based on those uptake, we can define the different stage of disease. We can use the quantitative measures to predict outcome of patients from the long term. We can also use to plan the therapy, and we can also use to study the efficacy of the treatment. For example, in the Parkinson's disease, as we showed the dead SPECT imaging, this is from a paper showing here, and we can see the uptake in the stratum gradually reduced based on the different stage of the Parkinson's disease. And if we measure uptake of the stratum and calculate ratio between the stratum uptake and the background uptake, we can find this. There is very good correlation between the activity ratios from stratum to the background as correlated with the disease stages. So based on that, we can use quantitative measure to more clearly define the patient and plan for diagnosis. However, there are many factors in SPECT imaging that may affect image quality and quantitative accuracy. This include attenuation, scatter, calorimeter detect response, which include both geometric and response and the septal penetration and the scatter response. There are also partial Raman effect, which is mainly caused by the limited spatial resolution, and there is a statistical noise of the SPECT image. So how those factors works? So ideally, when we have a point source in the object, we'll generate delta function with the ideal collimator. However, because the photon, when passing through the human body, it will interact with the human body, and it can be absorbed or scattered, which will reduce the intensity and which reduce the pulse of the signal we can measure as compared to ideal case. This is more severe for the source deep inside object because it's passed long and there's more attenuation. This is called attenuation effect. The second effect, the photon can also scatter in the object, and it can be scattered into the angle can be excited by the collimator. This is called the scatter artifact, and it's mostly scatter accompanying scatter. Finally, when the photon goes through collimator, because collimator is really ideal, it has a limited hole size, and the septal has a limited thickness, so there is a Gaussian-shaped function from the hole size effect. There is also the septal penetration. The gamma photon can also interact with the collimator and go through multiple scatters and still being detected. It can also interact with the collimator and generate characteristic X-rays, which can also be detected. This is called the collimator detect response functions. How do they affect image quality? So this shows the effect of attenuation. So if you have two spheres as shown here with same intensity, however, in the reconstructed image, we can see the spheres in the center of the image shows much less intensity as the one compared to the surface. That's because the sphere in the center has much more attenuation because the photon has to go through more distance to travel outside of body to be detected. That's why the center has lower uptake compared to the one on the surface. This image slices shows the effect of scatter. We can see without scatter, the reconstructed image looks very similar to the phantom. However, with scatter, we can see there is increased intensity in the center. As also demonstrated by the profile shown below, we can see there's a good agreement between the phantom and unscattered photons. However, when we add the scatter, we can see the whole uptake is increased. This shows the new effect of a collimator detect response as compared to different collimators. Medium energy collimator, which has small hole size but thinner septal, and this high energy collimator have a large hole size but thick septals. So this, when we're imaging an I-131 point source, which has very high energy gamma photons, which is 364 keV, we can see there's a lot of penetration for the thin septal collimators as compared to the thick septal collimators. And we can see the function of the resolution also changes with the distance from the source and the collimator. This shows the effect of collimator detect response in a spatial frequency and demonstrate the two different collimators, low energy high resolution collimator, which has small hole size. It has better resolution. That's why it has wider curves compared to the low energy general purpose collimator, which has a bigger hole size, which has worse resolution. And the overall the effect is very compared to a low pass filter as shown in the right. So this shows the effect of the collimator response function on the SPECT imaging. If we have a point source in the space from a different distance in front of a detector here, and we can see a reconstruct image. Those point source is blurred, and they're blurred in the different directions as different. The radial resolution and tangential resolution are different. So this is especially varying spatial resolution because of collimator detect response function. The blur caused by the resolution can also introduce partial volume effect, as shown here. If you have phantom with two spheres, one's dark, one's bright. After reconstruction, the image are very blurred. If I draw a profile, we can see the estimate activity in the high uptake regions is reduced. And the uptake in the low activity region is actually higher than the truth. So those reduced in the region is called spill out because activity is spill out to the neighbor regions. The increase in the region close to the high uptake region is increased. This is called spill in. As activity from high region is spill into the lower uptake regions. Both spill in and spill out can significantly affect quantitative accuracy, especially for objects that is smaller than 2 or 3 times system resolution, and they need to be compensated for quantitative SPECT. This shows you static noise effect on the image because the gamma emission is random processing, follow the Poisson diffusion. So measured activity also follows Poisson diffusion, and we can see when we have a more higher count, there is less noise in the image. This shows you overall effect of different degrading factors on the image. Here's a phantom, and when we have a perfect projection, we can see the image looks very similar to the phantom image. When we add attenuation, we can see the center getting darker because of attenuation effect. When we add resolution, the image is much blurred. And when we add scatter, the whole image shows up brighter. That's because the introduction of additional scatter can increase, serve as the low frequency uniform background, which increase activity. So as we said, we can compensate for this in the iterative reconstruction by carefully model the physics, including attenuation, scatter, and the collimator detect response, and all the some other factors. By carefully modeling those factors, we can gradually improve image quality and reduce the effect of those degrading factors. As demonstrated by this image, shows image reconstruction with the feedback projection without any compensation, as we see from the previous slides. And when we apply the attenuation compensation, we can see image looks actually close to the truth. And when we add the detector response function in the modeling, we can see the image resolution is improved. When we add the scatter compensation, we can see the image looks even closer to the phantom. So with this, we can gradually improve the image quality and also the quantitative accuracy. Now I will show you some examples of the application of quantitative SPECT. As I have showed you that that scan SPECT imaging is used for diagnosis or differentiate Parkinson's disease from normal patients. We can see here the normal patient with high uptake in the stratum and the low uptake in the Parkinson's disease. And currently, clinical reconstruction only includes attenuation compensations. As I have showed you, there is good correlation between the uptake of stratum and the disease stages. However, with the reconstruction algorithm used in clinic, which is not quantitative, we can only separate the Parkinson's disease, as shown the blue dot here, and the normal controls. So it's good use for differentiation normal versus patients, but it's not good for stage patients as shown here. There are very poor correlations between the uptake and the UPDRS scores, which identify patients' disease stage. So if we apply the quantitative reconstruction as shown here, this F3D is a Siemens Flash 3D used in clinic. It's compensated for the attenuation and resolution, but doesn't compensate for scatter. And our quantitative reconstruction method, which is a model-based method, you can see for these patients, the difference in the image between the clinical reconstruction and our reconstruction Again, for the patient 2, here shows the difference between our reconstruction and the clinical reconstruction. And if we measure the uptake of the stratum to the background ratios, we can see for the clinical reconstruction, there's a very poor correlation between the binding, the activity ratio of stratum to the background and also to the disease stages, that's indicated by the UPDR scores. And our method can greatly increase the slope of this curve, and also the correlation are much higher, and the significance multiple is more significant as demonstrated by the p-values for each of the stratal regions. Another example is the renal mass imaging. Renal mass are usually diagnosed from the enhanced CT/MRI studies of a patient. They are usually accidental findings. Among those renal masses, about 80% are renal cell carcinoma, which is malignant and they need to be surgically removed. And about 20% is benign, and about 15% of those are oncocytoma. Those are benign tumors. They don't need to be surgically removed. However, for clinical practice, both malignant and benign tumors are surgically removed with the affecting kidney, because in CT/MRI images, it's very hard to differentiate the RCC and the benign tumors. The biopsy also have 20% error rate, so the real diagnosis to surgically remove those tumors and do the histological study, this is very invasive and very costly, especially for those patients with benign tumors. So a group of physicians in Johns Hopkins come up with the idea, because oncocytoma is rich in mitochondria, it can be imaging with a SPECT agent called technetium-99 labeled cysteamide, and show in those images. This up image shows a patient, this MRI image, and the SPECT image showing very high uptake in the tumor. And that is the high uptake of cysteamide, which indicates it's a oncocytoma, which is a benign tumor, as demonstrated by the histological slices. And this is the CT images of different patients with large tumor as shown here. And we can see it has a lower uptake because it's a malignant RCC, and as demonstrated by the histological images. So we can use SPECT image to differentiate benign and the malignant renal mass. And again, we can demonstrate the difference between the clinical reconstruction, the flashy 3D from Siemens, image very blurred, as shown here. This is the amplified region of the kidney shown here, and also the same image we reconstructing with our quantitative reconstruction method. You can see the kidney is much clearer, and also the tumor. And if we amplify this, we can compare the two. You can see very clear defined tumor and the background. And if you calculate the tumor and the background activities, you can see the good separation between our method and as compared to the flash 3D, which is clinical reconstruction. So we can easily differentiate benign tumors and the RCC malignant tumors. So the other application of SPECT imaging is for the dosimetry in radiopharmaceutical therapy. Radiopharmaceutical therapy is a different therapy regime for cancer. It's used radioactivity labeled agent that target the tumor, and then the emission from radioactivities can kill the tumor. Most used the agent are like beta emitters. For example, IDA-131 is used for treat thyroid cancer, and lutetium labeled dotate is used to treat neuroendocrine tumors, and the lutetium labeled PSMA is used for prostate cancer, and yttrium-90 is usually used for treat the liver cancers. Those radionuclide, they will emit beta particle, which is the electron. It's elemental particle, very light, and it's very low, relatively low energy transfer, as shown here. And so it needs a lot of beta particles to kill a tumor cell, to kill a cancer cell. So it's usually like 1,000 to tens of thousands. And because it's need a large amount of particles to kill a cell, so the DNA damage sometimes can be repaired. And so you need higher dose to treat cancer. Most recently, there are more increased interest in use alpha particles to treat the tumor. Those include, like, for example, actinium labeled PSMA, treating for prostate cancer, and the radium labeled radium Dafigo, which is the FDA approved agent for treating the bone metastasis, and the thorium labeled HER2, used to treat breast cancer. Those radionuclide will emit alpha particle, which the helium nuclear is very heavy, and this has very high linear energy transfer, so it's only need 2 or 3 particles to kill a cancer cell, which can cause double chain break, which is irreparable DNA damage. So it's very effective when you treat cancers. However, all those treatment, we want to have higher dose to the tumor, but also want to do less damage to the normal tissues. For this, we need to do the carefully planning. However, currently the treatment planning used in the clinic is based on the patient weight, and so it's not optimal. And a recent study in Europe shown that a very promising yttrium-90-able agent for treating liver cancer has failed to demonstrate its efficacy in phase 2 clinical studies. The reason, as shown by these authors, is that they use a fixed dose for the treatment, so they didn't do the personalized treatment. So they retrospectively look into the studies and compare dose of patients. They can see, if we use personalized dose, we can have much better survival compared to the patients we receive standard dose. And more closely, if you look at the tumor dose, those tumors receive a large dose than 205 gray. They have better survival than those patients which receive a tumor dose less than 205. So it's very important to do the personalized dose. How do we do that? Then we can administer a planning agent, for example, a surrogate radionuclide labeled agent using indium or iodide, or we emit a low dose of therapy agent, and we can measure diffusion over the time with the imaging, SPECT imaging or PET imaging. Then we can calculate the organ dose over the time, which you can use planning for the treatment to calculate how much therapeutic activity we can give to the patients. So this is the basic principle of dosimetry. We need the accumulated activity as shown here, and that is the energy deposit for emission from this radionuclide, and the fraction multiplied by a factor. That means how much fraction of the emission from one source organ will be absorbed in a target organ, for example, from the kidney to the liver or from lung to the liver. This fraction is based on patient factor, and this also based on diffusion in the patients. So to calculate how much cumulative activity in the patients, we need to integrate activity as a function of time. Then based on this integration, we can calculate very important parameter called the residence time, which is the integrated activity divided by the attenuated activity. To achieve this, then we need to measure the activity distribution over the time. We can do this with SPECT imaging. We can acquire SPECT CT imagings over the time after you appreciate the imaging agent in the patients. We can measure them from different time. Then based on that, we can reconstruct each time point to the quantitative SPECT imaging. Then we can define a volume region tracing in the object based on the CT image, for example, liver. We can then measure activity in the liver as a function of the time. From that, then we can get what we call the timetic curve of each organs, showing the uptake of the radiopharmaceuticals in the different organ as a function of time. And from this, we can do a curve fitting to estimate integrated the area under this curve divided by the untreated activity, as I showed you earlier, which is the parameter called residence time. Based on that, then we can calculate the dose. So here's an example showing how the quantitative SPECT imaging can be used for the dosimetry studies. And this shows indium modulant quantitative SPECT, which is very commonly used surrogate isotope for imaging. We can see with quantitative SPECT image reconstruction, we can have really good estimation of organs, especially the small organs such as bone marrow. Its error is less than 5%, much less than 5%. So this is very accurate for SPECT imaging. This shows an example of yttrium-90 phantom studies. Yttrium-90 is used for treat liver cancers. It doesn't emit any gamma photons, so it's a pure beta emitter. So we have to measure the brightron emission from the yttrium-90. So it's very hard to image. Again, we demonstrate with the quantitative SPECT, we still can get relatively good accuracy, as shown here. This shows you the quantitative bone SPECT imaging, and this noise-free projection from simulation studies. This is the planar imaging, which is commonly used in clinic. You can see image is very noisy and the contrast is poor. This is the virtual planar imaging estimate from quantitative SPECT imaging. We can see the contrast better, the resolution is also higher. So if we measure the activity, and we can see there is a good correlation when we use quantitative reconstruction between the estimate activity and the truth. Again, for the alpha emitters, it's very difficult to imaging. One reason because alpha emitter has very complicated decay scheme. For example, so actinium-225 is very commonly used alpha emitter for cancer therapy, and we can see it's have multiple decay chains to different daughters. Some of the daughters can have really relatively long half-life. For example, the bismuth-213, which has a 45 minutes half-life, this can dissociate from the labeled chemicals and redistribute in the bodies. Then, in order to calculate radiation dose, we need to know both distribution of the parent compound, parent radionuclide, also the daughter radionuclide. So for this, we need to do the multiple isotope imagings. Again, we can see from this spectrum, this is the different peak emission from this decay chain, and this is the 440 kV from bismuth decay, and this is the 218 kV from the Frisian decay. And after energy resolution blur, you can see the spectrum is blurred. And when we add the scattering in the object, you can see the spectrum is further blurred, making those peaks very hard to imaging. So we have developed simultaneous multiple isotope reconstruction method as demonstrated by this flowchart, which we can use to reconstruction both parent alpha emitter and the daughter alpha emitters, which can produce the image of the parent's daughter at the same time. So we apply this to phantom imaging of thorium, as shown here, which decay to the radium, and we can see we can estimate the project reconstruction both radium and thorium. And when we use our model-based corrections, we reduce the error from 44% to 8%. We can produce very accurate activity estimate of alpha emitters for dosimetry estimation. So in conclusion, quantitative SPECT is possible with accurate and repeatable, which is similar to the PET imaging for the large object. There are methods that are commercially starting getting available. Both Siemens, GE has implemented quantitative reconstruction method in their commercial product. So they are available in clinic now. And to imaging small objects is still challenging because partial volume effect. Therefore, careful partial compensation is required. Because the reconstruction depends on the radionuclide and the decay chain, so it's not automatic processing as compared to PET. We only have 12 kV photons. Reconstruction is simpler, but for SPECT, you have to carefully validate the reconstruction method for each radionuclide. So there is still a lot of practical work to do to validate, develop, and validate optimal reconstruction for different radionuclide. And there are many applications under development. Again, there's, as we demonstrate here, quantitative SPECT imaging is very useful, and there is no reason we are not using it. With that, thank you.